Okay, great. Thanks for the introduction, Samantha. So as she mentioned, my name is Jackie Prevete. I am from Long Island. Just wanted to start out with a little bit about myself and how I got here. I'm currently in private practice in a sole podiatry practice in a group of all podiatrists. Currently, I'm from Long Island. I went to Fordham University. I graduated in 2009. I was a biological sciences major. What prompted my interest in podiatry is actually I am currently and still an athlete, but I was a track and field and cross country athlete at Fordham University. I am still running as much as I can. I've run 5 marathons. And that really piqued my interest in medicine itself. It helped me to steer my direction towards podiatry, just because a lot of injuries afflicted me during my undergraduate years. And I also served as team captain my junior and senior year and got to know my trainers really well because I was hurt. So it definitely kind of piqued my interest in medicine. And I kind of found podiatry on a whim, and I've never looked back, and I absolutely love what I do. And the rest of this talk is going to be kind of about how I got here, what led me here, and what my daily life is like, and why I'm so thankful for my career. We'll also talk about the track of everything as well. I went to NYCPM. I graduated in 2013, and I did a 4-year residency at New York Presbyterian Queens in Flushing. So we'll get into the educational background and kind of the steps towards private practice or whatever you choose to go into practice. But essentially everyone would do a 3-year residency. My residency at the time was 4, and I graduated in 2013. I served as chief resident in my 4th year. Once graduating in 2017, I joined Foot and Ankle Surgeons of New York, and I am currently a partner at that practice. I love being here. I love my practice. I love the people I work with, and NYCPM got me here. So it kind of all rolled into this great profession, and with working with a lot of great people that I constantly learn from. On top of that, I involved myself in the New York State Podiatric Medical Association, which is basically the advocacy body for the profession. So to give back to the profession and to promote the profession further, I became involved in the state association, which is basically a chapter of the National Association to represent podiatrists across the nation. And I'm currently a member of the board of trustees. So a lot of my personal involvement in that basically stemmed from my passion for the profession. And I'm board certified in both medicine and surgery, which are basically our own boards specifically for podiatry. And we'll talk about that as we go forward. So with that,
a little bit, I've heard really, really great things about your practice, by the way, and I've sent a couple people to shadow you and everything, and I've heard really great things about it.
Thank you. Yeah, thank you so much. Honestly, we're proud of what we built, and it's funny, so many people that work with us actually have applied to NYCPN and have gotten in, and they're currently students. So we're really proud of that, and we're always welcoming to have people shadow in the office and kind of come see our office hours and see our day in and day out. So thank you for bringing that up, and 100%, yeah, we would love to have that. So we're going to talk a little bit about what podiatric medicine is in general and give you a general overview. Essentially, the best way I can describe it is any issue related to the foot or ankle. It's surgical, it's non-surgical, it's medicine, it's dermatology. We can go to the next slide because some of that's listed there. But essentially, anything foot or ankle related, we do it. We are the best trained in foot and ankle pathology. It can vary from any sort of facet of medicine in terms of relating to the foot or ankle. So you're talking about biomechanics, meaning how the foot is functioning, weight bearing, non-weight bearing, in a shoe, without shoes, orthotics. So all of those mechanics, definitely part of what we do. Dermatology, if you go to a doctor and something's on your skin and you're typically at a bone doctor, that bone doctor is not going to treat your skin. If it's on the foot or ankle, we can deal with a bunion and we can treat the skin. So it definitely is versatile. You can really make this whatever you want, and you can even specialize within your specialty. We treat a variety of ages, children, older people. A lot of what we do also is geared towards becoming more of like a family practitioner. People with chronic illness, whether it's diabetes, whether it's nerve conditions, whether it's musculoskeletal disorders, where they have muscular weakness, they're going to be coming to you in a more long-term fashion. And I have patients that literally I see the whole family, and I've seen their whole family for many years at this point. And it's more so that you're becoming more of a family practitioner focused on foot and ankle pathology. We see a variety of vascular disease. We are also very much part of a medical team. Besides working with other podiatrists, we work with vascular surgeons. We work in conjunction with, neurologists if we have to refer, and even dermatologists for certain pathologies. Very much part of a holistic approach. Those of us that may not have access to a wound care center, we would send it to a colleague at the wound care center. So, everyone always says it takes a village. It really does, especially when you're dealing with complicated things. So aside from being focused on foot and ankle, we're part of a multi-specialty team and really part of the medical community. So at the same time, while we are specialists, we definitely have the variety to see a bunch of different pathology and definitely hone in on what we are good at, which is foot and ankle, anything.
I've always thought that's so cool about podiatric medicine is like, if you wanted to do everything, go ahead and do everything. If you wanted to only do this one specific thing, that's your prerogative. Do what you want to do.
Exactly.
But I think most people enjoy that variety and like that.
Exactly. And you can make it as you can go as complicated as you want, which we'll see in some of the cases, and you can go as simple as you want. But at the end of the day, the goal is to get the patient the care they need, and at the same time, improve someone's quality of life. So I think that's the best thing about this profession is that, you can make such a difference by doing something so small, but you can also do something so big and still make as big of a difference, if not more. So with that, the variety is the best way to describe this. So aside from we are a specialty essentially, but we specialize from the beginning. I'm going to talk about that a little bit more in terms of like the track you use to become a podiatrist. But I think another big take home point would be that, in your daily life, when you're through your schooling, you're through your residency, you're deciding what your life is going to be. You can choose a whole bunch of different things. You can be hospital-based, you can be inpatient-based, you can be outpatient-based. You could be part of a multi-specialty practice as well. You can go into sports medicine. Maybe you want to try and just focus on the biomechanical aspect and treat athletes. Definitely on the table in terms of your opportunities. You can just be involved in research, or you can do research in conjunction with private practice. You don't necessarily have to start your own private practice. You can join a group. It depends on what you want out of it. Essentially, if you're the type of person that you love wound care, you can definitely pursue a wound care facility. If you don't want to run your own practice and you don't want the kind of more administrative business side of it, there's no reason you have to do that. There are plenty of groups that employ podiatrists that are, just as an associate, or just as a podiatrist under a large umbrella of doctors, which is more falling into that multi-specialty category. So this definitely has variety in terms of what you want out of quality of life, which segues perfectly into the next slide. So essentially, what I love about this field is that you can work as hard as you want, and you can also have a great quality of life. I'm someone that I'm definitely more on the extreme side where I will just throw myself in and work. But there are people that don't necessarily want that. And I might not want that for my entire life as well. So there's definitely a flexibility. Another thing that I would bring up in this setting is that if you are in private practice, you can always kind of just, like I said, be an associate and work for someone. The other thing I would also bring up is that teaching is a big part of what we do. So aside from being in private practice, I work with residency programs, and teaching is such a rewarding thing that you can choose to get involved in or not. And quite frankly, teaching makes you and keeps you extremely sharp in all of your skills, because you're trying to instill that knowledge to someone else. So I absolutely love that about this field, and that in my daily life working with residents, I learn from them and they learn from me. So it's a great relationship, and you always are learning from someone else, which is wonderful. Earning potential, obviously, we want to kind of work to live. We don't want to live to work, which is a great way to look at things. You can have a really nice living. You can have a very comfortable life, and you can also have a great lifestyle from this profession. And I think at the end of the day, obviously we want something that's not boring and that's fun to do. This is most definitely fun to do on a daily basis. I'm never bored. And I also have a really nice life. And I think that's easily attainable, no matter how hard you choose to work and no matter how much effort you want to put into it. And most of all, you're making a difference in somebody's life. So I think all of those things are important to kind of keep in mind when choosing this as a profession. So just a little bit about the kind of course of action to how you would get here. You're essentially expected to do 4 years of undergraduate. If you aren't geared towards pre-med or some sort of science major, you can always take those prerequisite courses. You basically need the same knowledge under your belt as if you were pursuing an MD program, a DO program, a DPM program. All of those boxes needs to be checked off just because you do need the basic science knowledge. After the 4 years of undergrad or your prerequisite courses, you're going into 4 years of podiatric medical school. I am an NYCPM proud alum, and I think what does set NYCPM apart is your preclinical years are the same no matter where you go. You have your 2 preclinicals. I know Samantha might get into this a little bit more later, but the basic sciences, your first 2 years are the same for everybody, but the clinical experience that you get in your 3rd and 4th year is unmatched, and I think it makes the school wonderful, just because you're already interacting with patients and getting a flow as to how you're interacting as the doctor-patient relationship. So after your 4 years of podiatric medical school, you are doing a surgical residency. All residencies are surgical. That is something that the profession has changed over the years, but everyone is doing a 3-year surgical residency. Some people opt to do a 4th year. Some programs, although far and few between, are still 4 years. Majority, I would say, are 3. Some people also opt to do a fellowship year, which is essentially 1 year after your 3 years of residency. And that just gives you a little bit more of a specialized line of training in whatever fellowship vein you choose. And continuing education, I think that kind of goes for everybody. You can, like I said, be involved in a residency program. You could be involved in research. You never really stop learning in this profession. And I think that's really what makes it great. You're always feeding back to other practitioners. You're feeding back to your partners. You're feeding back to students and residents. So, and I think that's true of most fields in medicine. And I think that's kind of the right way to do it, just because there's never definitives when treating patients. You always have to take the patient into account. But I think continuing education just speaks to kind of everything rolled into one, and how, if you're involved in residency training, that definitely gives back to you as well. So my experience, this was like a really hard thing for me to kind of summarize. So I kind of put things in here to just remind me of like what my last however many years this has been. So going to the next slide, I was, like I said, some of my best and nearest and dearest friends are from NYCPM and are also from residency. So I think my experience has only been positive. I have made friendships and bonds that like I could never have imagined. And thinking to myself, like, if I had picked a different career path and I was like sitting in an office, would I have these relationships? And I would probably say no. I'm only saying that because I don't know, but I truly, truly believe that. So this is just a kind of like picture of what these last few years have been. It's just been invaluable relationships, not only with my co-residents, but with my classmates, with my partners at work. Like I said, I'm part of, I think eight doctors and 7 office practice. So we are a relatively large practice, but, the best way I can describe it is that, we're all constantly bouncing ideas off of each other. And that's kind of the best way to do this, is because the way you treat your patients better is, just to kind of be up in the most current way and the most advanced way to get them the fastest care. And I think, to have such a large network of doctors that are thinking in a similar way, I think that's the best thing for everybody. So we're going to go through a couple cases or a few cases that kind of just summarize a little bit in more of like a pictorial way of what daily life would be like. This was a young girl. I think she was like 11 or 12. She had this condition, which is basically a shortened toe on both feet. So her left foot in the top left picture was already done. Her right foot, she had it on 2 toes. So this was a procedure that I had done. I can't remember how many years ago. I had done her left foot first. And then her right foot was subsequently done. I don't have a final picture of the right, which would have been like way more effective for this, but you can kind of see what it looked like on the left. She still comes to me for random other things that don't have anything to do with her short toes, but this is one of those things where it's mostly cosmetic. It can cause pain and difficulty with shoe gear, but super rewarding to do and also really fun and a challenge, especially because they were like right adjacent to each other. That picture all the way on the right basically is the device that we would use or the patient would turn, just so you have an idea of how this works. But this was not only really rewarding for the patient because she had a really great result, but also really satisfying to do as the surgeon, just because it was a great teaching case. And it was also a challenge, which sometimes people don't like that, but in certain circumstances, it keeps things interesting. So this was a really good example of kind of just one of the things we do. This was a very difficult case. So I would highly recommend, this is not a one-person job. This is a gentleman with longstanding diabetes and a really, really bad, what's called Charcot deformity, which is basically the bones kind of changing shape over time as a result of neuropathy that you get with diabetes. This gentleman was really unable to walk on this foot. It was so dislocated, deformed. This was chronic. This was years. He had been recommended to have some sort of surgical procedure to realign it just because he was so limited in his ability to walk. He always shied away from it because it was such an undertaking. I will admit this was a really difficult procedure, and you know, if this isn't what you want to do, that's okay. I will show things that are definitely not as stressful as this, but this was also a really big challenge and made a huge difference in his life. I mean, just to put things in perspective, someone that really can't walk with diabetes can't really move around to control their diabetes. So it is a catch-22. You do have to think about this in terms of their lifestyle. And obviously you explain the risks to the patient just undergoing the surgery in general, and you do have to be forthcoming with them. So it does give you a little bit of a lesson in honesty and the doctor-patient relationship, which is so important in these cases. But this was a foot that literally was turned like 90 degrees, and it was a crazy case, and it was really rewarding. And this isn't the final construct on the right. Eventually it was internal fixation. I just didn't put the x-rays up, but this was done over time and in a staged manner with 2 major surgeries. And he has the other side to do next year. So I guess that's going to be the next step. But he's doing great. And again, this is definitely like on the scale of more challenging, more difficult, more stressful. But this just shows the depth and the kind of broad spectrum as to what you can do with this profession.
Could you quickly touch on the importance of podiatric care for people who have diabetes in general?
Yes. So I actually have a slide, the last slide, I'll talk about that too, but yeah, so essentially kind of going back to what I said before, aside from the crazy surgical stuff, diabetic care is something we are so instrumental in. You know, it's not just kind of doing all this reconstructive stuff. I mean, this is saving a limb and even preventing limb loss. So a lot of what we do in terms of the diabetes is having people in for screenings, assessing them for risk. Are they neuropathic? Do they have circulatory compromise? Are these things that would put them at risk for a wound or an infection? So we are the first line of assessment for that. You know, I mean, if their endocrinologist knows they have diabetes, they're going to say, they might look at their feed, of course, you know, they're going to give them like a once over, but they're going to say, listen, you need a podiatrist, you know, that's going to be their first recommendation. And, you know, as the first line for that, we're sometimes the first people that pick up peripheral vascular disease. They might not have a problem. We're the first people that pick up, you know, early neuropathy. So in that way, like I said, we are part of like, someone sees their podiatrist more than they see their primary care doctor in those circumstances. And that is by far the truth. So that is instrumental to what we do for sure in terms of preventative medicine and also, you know, urgent care when the time calls for it in the case of an infection. This was another case, mostly cosmetic, but also kind of cool. This was a girl in her early 20s, congenital deformity, her toes are webbed. So we unwebbed them. This was more of a graft taken from another part of her foot that was implanted between the toes. And on the right, you can see the final product. She had a little bit of a post-op complication because she was slightly non-compliant, but we ended up fine. Sometimes it happens. But overall, again, something so simple. This was no bone cutting whatsoever. This is purely a cutaneous skin level condition. The challenge of this was just the cosmetic appearance of it. That was the only challenge in this, but you literally, to do this procedure, only need a blade and some suture. That's it. Could be as simple as this, but again, you know, it's also more of a cosmetic thing. So patient expectations, but at the same time, a rewarding results and makes a difference in her life. I actually suggested medical tattooing before I did this, and she said, no, I want it done, and we did it. So.
That's kind of cool. I didn't even think about medical tattooing as an option.
Some people do it, but yeah.
How much of the surgical procedures that you do, how many of them would you say are optional?
So optional is a good way to put it. This, you know, I tend to use the word like elective.
That's the word I was looking for. Thank you.
Yeah. So a lot of the time when people come in, most of what we do, not most, I would say some of what we do, and I would say more of the majority is what's called elective surgery. So that doesn't mean it's not necessary. That doesn't mean, you know, it's not warranted. Elective surgery means that it can kind of be planned in advance. You know, a bunionectomy would fall into elective surgery. You know, something like this, elective surgery. But it's something that, you know, improves the patient's quality of life and basically makes them happier and allows them to do the activities that they may not have been able to do before, which ultimately improves the health of the patient. So of course, elective surgery most of the time is on an outpatient basis. There are plenty of surgeries that we do that are not elective, that are more trauma, infection, things like that, things that where the patient doesn't have a choice. You know, they have to undergo the procedure, otherwise they could lose their limb. In more of the elective realm, you know, it's a lot of what we do, but it's still, you know, this I would say definitely falls into the more cosmetic, or this was more like still elective, but cosmetic, you know, and this was something that the patient did really want and opted to do. In those settings, I'm just a little more conservative in terms of like my explanation to the patient as to like what the expected results are. In my experience with that, patient expectations are everything. So you just have to set it up so the patient understands what they're going to get out of it. But elective surgery, which I think this probably would be falling into that category, ultimately improves the patient's lifestyle, quality of life. This was another one. This is a young kid. I think he was 17, 18. I can't remember the exact scenario, but pretty much sustained a large laceration. I think it was some sort of like electronic scooter, I believe. And this kid got so lucky. Basically, where you're seeing that left picture, sorry for the picture. But
it's the worst one. The rest of them are much better.
The worst one. But he basically missed pretty much every major tendon and artery in the foot. And we were able to repair it, and he's fully healed with absolutely no deficit. So this is one of those things where not really elective, didn't have a choice, needed to happen, and worked out for the better. So, you know, and again, this is, although stressful in that this kind of had to go when it had to go, you know, we couldn't just wait and do it when we felt like it. To do this, it's really just making sure the tendons are okay, making sure the major vessels are okay, and just reapproximating the skin and making sure it heals and knowing when to start moving it again so everything heals appropriately. So again, like on this more stressful side in that, you know, the doctor doesn't have a choice as to when it goes either. The doctor just has to be there. But this is something where ultimately it was a skin laceration that was very deep, and the result ended up totally fine. So this was another good learning case as well.
Yeah, lucky kid.
Yeah, very lucky. So this is, again, we're not electing to do this. This is an ankle fracture. There's a couple different cases kind of melded into one slide, but I figured we put it all together just as one. So this was a couple different injuries, but the main gist is a slip and fall. They can be really bad, like the one on the right, which required closed reduction, which basically means put on an external fixator if the closed reduction fails, which you see on the left picture. And ultimately, the goal is to restore the ankle joint, which you see in that central picture there with internal fixation. These cases are definitely more of the challenging ones, but not, nothing that the patient isn't wishing for this. Like this kind of just happens and it has to get done. But trauma is, when you're dealing with a fracture, to me is so satisfying just because you're only going to help the patient. And they didn't want this. It happens. It just happens. It's an accident. So essentially, this was one of those scenarios. This is a very common thing that we see. And, these are, fun cases to do just because, again, there is a challenge to it. But, this is basically more so like you're on call at a hospital, you're working at an inpatient institution, you probably are teaching residents as you're doing these more likely than not. But again, definitely rewarding just because, it has to get done and it gets fixed and ultimately the patient can use the ankle again. Otherwise, this is a tough situation. I've had a patient in a similar situation to that picture on the right, and she just refused surgery. And it was a really tough situation just because, it's, you really can't leave it like that. It's not a functional joint in that position. So
do you know how that ended up for her?
So she was just deathly afraid of the anesthesia, and ultimately, she's going to require basically an ankle fusion if you can't fix it and realign it. So she's aware of that. I think she just has to get over her fear of anesthesia. But yeah. So this is another very simple yet effective case. This was, I believe he was like 8 years old. I was a resident on this case. And this was done bedside. This was an open fracture. But luckily, there was a fracture there. The fracture healed on its own, but the skin was kind of sutured up, reapproximated. And again, super satisfying, nothing that we planned, but, it ended up fine, healed up, and he was young, which also helps, but, otherwise looked fine at the end. And then, the next slide. So this is where we kind of get into like the diabetic realm of things. Aside from trauma and elective surgery, we have such a large role in diabetic limb salvage wound care. So these are just some pictures of patients that really have longstanding diabetes, and they don't have a choice in the matter. They have to have their wound healed. Some people, especially in longstanding diabetes, where you're dealing with people with kidney disease, or they're on the list for a kidney transplant. Like they're not going to get that kidney transplant unless you heal their wounds. No one's going to allow them to, for risk of infection. So we do play such a large role in the whole picture of the patient as a whole. And I think that's where, people think podiatry and they think foot and ankle. And yes, of course, like we're definitely the best trained and the best equipped to deal with foot and ankle pathology. But people also have to understand, we are instrumental in getting the person back on their feet so the rest of their medical issues can be handled. And that's another point I would make. I mean, just to kind of reiterate, we are a specialty, but we specialize from the beginning. We go to podiatry school, we end up with a DPM, which is a completely different degree. And that degree means that we have a specialty in and of itself. We don't take the same licensing boards that an MD and a DO takes. They have separate boards in and of themselves. We have our own licensing board because we are specialized from the beginning. So if a general surgery resident went to take our licensing exam, I don't expect them to pass because it's so specialized from the beginning. And people have to realize that and remember that. And that's why, our training is also, 4 years of school, 3 years of residency. And those 3 years of residency, you have rotations, but you're foot and ankle all the time. And even someone that specializes, people that look into podiatry may have also looked into orthopedics as an MD. But as a foot and ankle ortho, you're doing a fellowship in foot and ankle. Most of your residency is hip and knee and other joints. As a podiatrist, your residency is foot and ankle. That's it. So, and that's what it should be. We see the most related to the foot and ankle, and we are the specialists of the foot and ankle. And I think that's really, really important to remember.
Absolutely. And just touching on the limb salvage aspect, I have this fact that I throw out often is the mortality rate for after a lower leg amputation at like 3 to 5 years after is up to 70%. Yeah. So that's a pretty massive mortality rate after an amputation. So to keep their leg is a huge factor.
It is. And you know what? I mean, even in these really tough cases, people are coming to you because people probably come to you and they've probably already been recommended to have an amputation in some circumstances. And they're coming to you because they're not willing to accept that and they want you to do something about it. So if they're in your office already, they want you to save it. And you can. I mean, you have more than enough potential to do it, in this field, and you have so many resources available to you. And I think that's a really important point, is that you're decreasing that patient's mortality and putting years onto their life by doing what we do.
100%. And I actually already have a question for you, and you kind of touched on it a little bit, but if you could expand on kind of the overlap between DPM and orthopedics as far as surgery goes.
Yes. So that's a great question. So essentially, in terms of what we can do as DPMs, in New York State, these scope laws are limited, but ultimately we can do almost everything that a foot and ankle orthopod can do, aside from total ankle replacements and what's called a pilon fracture, which is an intra-articular fracture into the ankle joint. They're much more involved. The complication rate is higher. In terms of any other surgery on the foot or ankle, we can do with certain licensing in New York State. So there's a graduated process once you get out of residency and once you're in attending to apply for those licenses. In your residency, you will be exposed to any and every foot or ankle surgery that both orthopedists and podiatrists can do, more than likely. I mean, you will probably see a total ankle replacement in your residency at some point, depending on where you train. In New York State, you are unable to do a total ankle replacement as a podiatrist. And that varies by state. I would say some podiatrists do in other states. That's definitely on the table. But the short answer to the question is, and it depends on state scope laws, a podiatrist surgically pretty much overlaps with a foot and ankle orthopod in terms of what they do surgically. It just would depend on those specific state laws, because they do vary depending on where you are and depending on your scope.
Okay. And what would that competition, or is there any competition? Like, how would that look like?
Between orthopedics, you mean?
Correct. Yes.
So honestly, I've only had, like, in my experience and in my years, I mean, I trained at New York Presbyterian Queens, and they have such a strong orthopedic presence. And I've only had good experiences with orthopedics. I mean, we co-scrubbed cases on the trauma service. I rotated with ortho for 2 months just to get an idea of the other things they treat in terms of hip fractures. We share ankle call at the hospital I take call at, which is great. I mean, I feel really, it's not like that everywhere, I will say, but I was fortunate enough to have a really great experience. I literally did a case today that we're sharing with the trauma service. So, I mean, I don't think that it's always like a turf war, I would say. I do think that would vary in certain places for sure. But I think overall, there's enough people in the world that it shouldn't be an issue. And I think, we do have the training to do it. That wouldn't be the case. I mean, as long as, it depends on your residency, obviously, but, if you're doing a residency with the training, it should be an equivalent thing for sure.
And I've also heard, and I don't know this to be true, but I've heard that a lot of orthopedic surgeons or to-be orthopedic surgeons might stray away from specializing in the foot and ankle because they know that DPMs are those specialists anyways. They might, opt to do something different.
Yeah, I mean, honestly, and like I said, as a resident, we actually co-scrub with the residents from Hospital for Special Surgery, and I had such a great experience that I learned so much from them, and they're great people. They still rotate there, and a lot of them, I can't really speak to the reasons why they don't go into foot and ankle. I know a lot of them, at least when I was there, some of them went into kind of like sports. One of them was going into spine, which is a really tough field.
Mhm.
But I would honestly say, I never had it was a malicious thing between us. Obviously, there is, I guess, like a turf kind of thing, especially when you're taking ankle call and you're sharing it with orthopedists. But yeah, I mean, I think there are certain people that do want foot and ankle, and if they're ortho, they do understand that podiatrists are basically, we do this similar, we treat similar things.
Mm-hmm. Yeah, and you are that specialist a little bit earlier, so it's a quicker path for you guys too.
Yes, it is a quicker path. And people sometimes, I think a large misconception is that people interpret quicker path to less training. And I don't think that's necessarily the case. Yes, it's a quicker path. Yes, there are fewer years that we're spending, but that doesn't necessarily equate to less experience. That just means that the experience is concentrated into a much shorter amount of time, and there's just less of a broader experience. I mean, another example would be at my residency program, we actually admit and manage patients primarily on our service. So, when the patient's admitted to us, we're managing a lot of the medical issues they have. And of course, when we're doing that, we're getting a medicine consult and a medicine attending on board to help us with that. Ultimately, we definitely do the other rotations in terms of like general surgery, medicine. We have the experience, we do emergency medicine. But just like anything, I mean, you're not going to go to a dermatologist if you have an eye problem. So it's kind of the same thing. I mean, we're specialized in the foot and ankle. So anything foot or ankle is our niche. So I think that's a good take home point either way. I think it just because it's a quicker path doesn't necessarily mean you're lacking in the experience. I just think it's a more concentrated amount of time you're spending learning exactly what you're focusing on.
I agree. Thank you for explaining that.
Yep.
And also I got a couple more questions.
Sure.
One of them being, so from undergraduate to where you are now, what would you say was the most challenging part of your career?
Great question. I will honestly say the first couple of years of school at NYCPM were very challenging.
I try to warn people, but they don't believe me.
No. So I will very honestly say that the preclinical years at NYCPM are no joke. You really are, you have to learn a lot of material in a short amount of time. And you just have to be on top of it. I think, and don't get me wrong, my residency was tough, like really tough. I'll get to that in a second. But I think the first 2 years of school were just, they were mentally very, very tiring, and it's so worth it. I mean, it's literally a very short, in the grand scheme of things, in the span of your life, it's not a large sacrifice to make. You definitely sacrifice some family events and social time. But it's so worth it. But I will say the first couple of years of NYCPM were challenging, and challenging from an academic mental standpoint. I would say my residency was challenging from like a sleep deprived learning standpoint, and very much stressful in that, like, you don't want to make a mistake, but residency is also your time to make a mistake and learn from it. So I would say those two things were probably the most challenging. Now I'm challenged in a different way, but I have more control of that challenge, I think.
Okay.
Yeah.
And then what would you say, switching gears completely, can you talk about the presence of DPMs in more rural areas? Obviously, you are located in New York City, right? But what is your experience or knowledge of people who are working in some of these smaller areas?
I can't speak to that too much, but I will say some of my co-residents went to much more rural areas. And what I would say is you're it. In those less populated areas, there might not be a foot and ankle ortho. You're the guy. And in my experience, or at least the people I know that have moved to other places that aren't as like heavily saturated, you know, you might be the only foot and ankle person at that hospital. So you're doing everything. So I think in general, that's not such a bad idea, depending on how hard you want to work. And I think New York is its own kind of realm. And it adds a little extra layer of challenge, but if you were to relocate somewhere and you're going to Oklahoma, you might be the only doctor there that can treat these people. So I would venture to say, I would say if you're not the only one, it depends on where you are, you might be one of the few.
And you're making a lot of money in those instances too, because you are that only person. I know a couple of our alums that have done that and want to give back to the people in these rural communities. I know one very specifically who's in a rural area of North Carolina who's just killing it.
Yeah,
very busy for sure, but absolutely killing it.
Yeah. I mean, I don't doubt it. I mean, here it's a little different because, like, you know, people in New York City, they come into a doctor and they've been to 3 other doctors that day and you're your fourth opinion. Like, it's definitely a different way of thinking altogether. But I will say, you know, it's definitely hard work, but you're the person.
Absolutely. And again, switching gears, what would you say are some very important qualities for DPMs in general?
Great question. So honestly, I think the way to summarize this is, you know, this is definitely, I mean, you have a great quality of life, but like to be good at this profession, you do need a sense of empathy. You know, because of the variety, sometimes, and it's so funny, sometimes it ends up like this. Like people come in with something so severe, like, you know, they have a severe infection and they're like, oh, I didn't even know it was there. And it's like, oh my God, like, you know, you're trying to like talk sense into them. And then people will come in with like, you know, my nail doesn't look right. And obviously that can be very serious if it's like a skin cancer or something, but it's such a variety of pathology that you're seeing. Some of it very serious and some of it may not be so serious to you, but it's serious to the patient. And I think what this profession needs in general, and for any doctor, is empathy. You know, you need to empathize with the person that's coming to you for advice. You're the professional. And you have to understand that, like, from their perspective, they don't have the background you have. So you have to understand that they took time out of their day to come see you, to talk to you about this problem. And I think empathy is a super, super, super important quality that I think that can go anywhere in medicine. That's not necessarily for podiatry. Podiatry specific, I think a really good way to approach things is education for patients. I think patients need to understand how important their quality of life is, and their feet lead them to that. So I think, you know, someone in the profession that wants to educate not only, you know, residents and students and the patient population is probably more important because people need to know what we do. And I think common misconception about the profession in general is that people don't know what we do. I mean, yes, we cut nails, but we do so much more than that. And I think that's probably the most important thing I would say.
Okay. I definitely agree. So what would be some reasonings why someone would or would not decide to do a fellowship after their residency?
Good question. So I would say some reasons people would not would be that they kind of want to just go into practice. They felt like they had like really well-rounded training and residency. I did a 4-year residency. I wasn't going to do a fellowship. I felt like I kind of like covered my bases. I would say people would want to do a fellowship if they want that like subspecialty. So say they want to do sports medicine, or they want to get really good at arthroscopy, you know, like arthroscopic surgery, and sports medicine would help them do that. That's when I would say that they would do a fellowship. Or they want to master forefoot surgery and they want to, you know, whatever the case may be. They basically, if they want to specialize within the specialty. Or if they just want another year of training, I mean, that's totally fine either way. I think normally that decision is made kind of when you're a resident and you kind of see where you stand at the conclusion of the 3 years.
Yeah, so there's no right or wrong way to do it, right? It's just
Not
a
at all.
personal.
Not at all. Nope. It's all about what you want to get out of it.
Okay. And what has been your experience about working on the board of trustees representing podiatrists nationally?
Yes. So I absolutely love my experience. I actually became a member of NYCPM as a resident. And I got involved My residency director was Dr. Lombardi. And if anyone knows Dr. Lombardi, when he tells you to do something, you do it.
I do.
So I got involved as a resident, and I have not looked back. I absolutely love my involvement. So the NYCPM is actually, I mentioned it before, but we advocate on behalf of the profession. We don't advocate for surgery or medicine or anything. Literally, we advocate for podiatrists at the state level, and also are part of the national chapter to advocate at the national level. So I became a member in I was always a member, but more involved, I would say, in 2016, and then was elected to the board last spring, which I am so thankful for, and I absolutely love serving on. Anything I can do to kind of have people understand what we do, and have people understand that like it is a really good field and people just don't know about it. I absolutely love just kind of doing that, and having just people have more knowledge about what we do. So
that is basically my job.
Yeah, I think it's great.
Have you worked on public policy at all?
So I'm involved more. So we have a lot of that stuff going on in terms of just like public health in general, and efforts we're making towards that, kind of getting podiatry at the center of medicine in general. I'm actually more involved in trying to change the scope in New York State a bit, and we're trying to kind of move that in the right direction. I'm also involved in the young members portion, just kind of getting young people involved, and making sure young people are advocated for. So that's kind of more of where I stand in the state association. But, you know, I mean, the board that I'm part of is just literally a lot of great people in one room with amazing ideas. And I'm just really happy to learn from them. I'm obviously one of the newer members, so this is a really new experience for me, but it's been so rewarding, and I'm really thankful to have the opportunity.
Okay. And when you're picking your residency, how important would you say that choice of residency is in terms of like the greater scope of your career or subspecialties, stuff like this?
I actually think residency decision-making is a pretty big decision. Honestly, I think, you know, residency is the time, and obviously like with school and, you know, school being a challenge, you know, you're kind of looking for a break, and I would strongly suggest that residency would not be that break. I mean, residency is your time to work, really, and it's not the same kind of work like sitting and studying for a test. It's seeing, doing, and teaching all rolled into one. And as you kind of graduate through the years in your residency, that is your time to learn as much as you can, make mistakes, work with a bunch of different people and see what they do, watch other people make mistakes and learn from their mistakes. I mean, residency is your time to essentially do things with guidance, because when you're done, it's you. I mean, I had like such a solid, I mean, I loved my residency. Like I hated it sometimes, but I loved my residency. And I felt like I had like a solid 4 years, and I still came out like, oh my God, like this like burden of it being me responsible for so much is, it's stressful. And I think residency, even with a good residency, that's still there. And that's something people don't really prepare you for. That's more of like an emotional stress. And, you know, you get through it. Don't get me wrong, you totally do. But residency is your time to kind of get over that hump and say like, I did this already. And I remember what Dr. So-and-so did when they were in this situation, and I know what to do. And residency gives you that confidence. So I would say, you know, choose wisely, and, just try to go to a place where you know they're going to, you know you're going to work. And obviously you get breaks here and there, but I would say those are valuable years, and try not to sell yourself short on that. That's a really important experience, because that's where you're going to learn with the comfort of having someone to help you.
So if you wanted to be like a sports medicine podiatrist, right? That's your dream. That's all you've ever wanted to do. And you were thinking about residency programs. Are there really residency programs that are specializing in these subspecialties, or is that going to be more of the fellowship after the residency?
I would say that's more of the fellowship, but I think sometimes if you do a little bit of research, and especially during your externships, you know, like your 4th year of school where you're rotating through these programs, there are some programs that have like, some programs do like a ton of trauma, say like they do reconstructive surgery. Some programs are, they have an attending that does like, 16 bunions a day, and if that's what you want to do, you'll have that experience. Sometimes it does take a little bit of your own research to kind of like see which programs have more of what. And that's such a hard thing to gauge, as an extern. I think the school does a good job at like kind of guiding you in the direction, but sometimes it's just really hard to know until you're a resident there. So I do think like if you really wanted to specialize and you go through your residency, fellowship is a good way to do that. But sometimes you just get lucky. And if there's a residency that does cater to your needs, it can be done with residency too. It just takes a little bit more of like that, like fine tooth comb as to like what residency program does that for you.
Okay. And what is a piece of sage advice that you have for people in their first year of podiatric medical school?
First year of podiatric medical school?
Uh-huh.
Stick it out. Honestly though, just it does. I will say like it in my first couple years of school, especially the first year, it feels like there's no light at the end of the tunnel, but like there really is. You have to get through the preclinical stuff. And you have to, and one thing I really will say, it does get really, really daunting in school with like this exam, that exam, anatomy, physiology, like all that stuff. It's a lot of information. The one thing I will say that's the most important, that will literally make your life easier. If you're going to devote like all your time and effort to one class, it's lower extremity anatomy. Like that is so important. If you know your anatomy, your lower extremity anatomy, general anatomy is important, but lower extremity anatomy, like when you're a resident or when you're a student in your externships, you're guaranteed to get an anatomy question. If you know your anatomy, your life is just so much easier. Literally, your life is just easier.
Are really complex as well.
Yeah.
So
yeah, there's a ton going on. So that's why they have a whole class for it. But that is like literally my most important advice is like if you're gonna strive to get an A in any class, go for lean.
Okay, heard.
Yep.
Can you speak to the process of board certification?
I can. Yes. So board certification is typically done by the surgical board. So it's ABFAS, American Board of Foot and Ankle Surgery. Essentially, that process it begins really when you are a resident now. They did change it. So when you're in your third year of residency, and typically every year of residency, they make you take what's called like an in-service exam. It's basically, an exam every year that mimics your board exam to check your knowledge. Okay. Now they've changed it where your third year of residency, you take this exam and it does count for your board qualification status for ABFAS. Okay. So they're saving you time and money, which is excellent. I did not have this, this is heading in the right direction. So essentially you take this test through ABFAS and you come out of residencies, provided that you pass board qualified. So what board qualified means is that you are pursuing board certification. Board certification is typically split up into foot certification and RRA, or reconstructive rear foot and ankle surgery certification. So you can pursue one or the other. So just because you want to be board certified, it doesn't mean you have to do all the other complex rear foot surgery if you don't want to do it. You can just be certified or qualified in foot surgery. So say you went to a residency program where you didn't have as much exposure to that and you're not pursuing an RRA, that's okay. You could just take the foot section and be certified or qualified in foot. So you graduate if you pass board qualified, and then to become board certified, you essentially take another test, which is kind of like a patient simulated test. It's called the CBPS, which is computer-based patient simulation or something to that effect. It is on the computer, and there's cases where they give you a picture or a scenario, and you go through the stepwise process of diagnosing and treating that patient. The second facet to certification is your cases, which basically you would get out of your residency, you as the attending on record, you submit those cases and they have to pass through a board who examines those cases. You submit the x-rays, the notes, and then you are board certified. There is a process for foot. There is a process for RRA. It is a difficult process. It is a difficult process. ABFAS is a very, very reputable organization. They make it worth it. And I think that's a good thing because, you know, it should be something that people strive for, and it is attainable, but it's work, and it's work that's worth it. So I would say that that's kind of your track towards board certification. There's a medicine boards as well for those of you that may not want to be as heavy surgical. And that is a different exam. It's ABPM, and it's a different board. So our profession is split into 2 different boards. That changed also. Whether that's a good or a bad thing, it is what it is. But there's 2 different tracks to board certification, one surgical, one medical. If you choose to maybe not be a surgical, you can be certified in the medicine boards. That is okay. And that process, I believe now, I think they used to have you take 2 exams, but I don't know if they've condensed it down into 1. But just the short answer for certification, board certification, it's surgical, which is ABFAS, and medicine, which is ABPM. The ABFAS process is challenging, but attainable. And it does take time to do it, for sure.
And obviously this field has changed a lot, and you touched on some of those changes, but how do you see it changing in the future?
That's a great question as well. So honestly, I think this field has evolved, some for the better, some for the worse. I think, you know, and that's with any profession, you know, you delve into any profession and there's gonna be positives and negatives. And I think ultimately the big picture here is that, you know, we're a profession that, again, has such a variety of ways to treat people. You know, people come out of a surgical residency and they might not want to handle the high stress level of surgery, and that's okay. People come out of a surgical residency and they may want to do a whole bunch of stuff and put an X-Fix on and involve themselves in a little bit of a riskier type of environment, and that's okay also. I think as a profession, we need to kind of unite everybody. We have to understand that, you know, we all have the same 3 letters after our name. We all are DPMs, and no one should really kind of think that they're better just because they do all this other stuff. I mean, we're all one profession, and I think what we could do better is kind of support each other. I think, you know, there is a little bit of a divide between the surgical and the medicine type of avenue here. I think, you know, whether or not we think that's a good thing or a bad thing for the profession, it just is what it is. And I think, you know, the surgical boards are the surgical boards and the medicine boards are the medicine boards. And I think as long as they kind of stay within what they say they're going to, I think that's fine. But ultimately, you know, again, we all have the same 3 letters after our name. We all, like, even if you do major surgery, you know, you're still seeing ingrown nails. I mean, and you're still making someone's life better. So it's not that, you know, one's better than the other. It's a profession as a whole. And you know, I think some of the changes they've made, we want to obviously strive to advance the profession, but we also want to know that we've evolved a lot and this profession has changed even in the past 10 years. So the people that might not do a lot of the surgical stuff, that's okay. I mean, you're still part of this profession and it's still just as rewarding for them as it is for everybody else.
It's a very nice sentiment. And the last question that we'll have you speak on is, how did you cope with like stress or anxiety during med school or during your residency?
I ran. So as I said, I'm a runner, and running was like a big stress relief, you know, just in terms of exercise and endorphins and clearing my head and, you know, having like 40 minutes away from my phone, maybe not when I was on call, but, you know, other times definitely. But yeah, I mean, I think that was the biggest thing. I think my family was super supportive. Really important people in my lives. I mean, everyone has a support system in times of stress, and I think that's the biggest thing. But you know, ultimately, if you choose to do it, you're going to find your way, and you're going to do you, and you're going to find what works for you. And I think also just stress management in general, like, and I think I still feel this a little bit as a practitioner. you kind of have to take care of yourself a little bit, and kind of just compartmentalize things when things get overwhelming. I mean, I think me as a doctor, like an attending, people don't really prepare you for like the emotional stress sometimes of like being responsible for having so much change or ability to change someone's life, either for the better or for the worse. And that just comes with the territory of just being a doctor. I mean, we make big decisions, and sometimes some decisions are bigger than others, and some impacts are bigger than others. And I think you just have to remind yourself that you're only human, and stress is the thing, and you have to kind of take time to make sure that you take a break once in a while and kind of know your limits. And if you reach those limits, just lean on people that you have for support. I think that's the best way to put it. And also talk to people that have been through it. And I'm lucky. I mean, the people I work with are amazing. I mean, I always can ask them for help. And I only hope that people would find that environment as well for themselves. So.
Okay. Thank you, Dr. Prevete. This has been great. I really enjoyed it.
Yeah. Thank you for having me. I'll stick around if anyone else has any questions, but I really appreciate the time, and I hope it was informative.
Of course. I'm going to go ahead and take it over. I'll very briefly go over some admissions related stuff and some NYCPM specific things. So application procedure, you apply through ACMAS. It's a lot of words. I'm going to call it ACMAS. It's the easiest way to do it. Obviously, we need your official documentation and everything. And we are very able to help you throughout all of that. So if you wanted to do like a virtual advisement session with us, I can like look at all of your documentation and kind of talk you through what is or is not going to help you in that process. We have both a January and a fall start. So we say it's never a bad time to apply to NYCPM. I think our application is only not open for the month of July. The rest of the year it's open, just depending on what term you were applying for. Our prerequisites are relatively standard as far as applying for med schools go, right? We need a full year of bio, a full year of chemistry, a full year of organic chemistry, a full year of physics and English. Our average MCAT is about a 498, GPA 3.2, 3.0, depending on whether or not it's science or overall. We need 3 letters of recommendation, and we ask that one of them be from somebody who knows you academically. So we don't require any podiatrist to write you a letter of recommendation. Obviously, it looks great, and we love to see one of our alumni writing a letter of recommendation, but it is not required. You can also do the pre-health committee evaluation if you have that at your undergraduate institution. Okay, so like I said, we have a January start as well, and we're actually the only podiatric medical school to do this. So basically how that works is it would take you 4.5 years to graduate instead of 4. So it gives you a lighter course load for your first 3 terms, which equates to your first year. So you get a little bit more time to get your feet underneath you. I mean, Dr. Prevete talked about how difficult the curriculum is and how much people struggle, right? It is an adjustment period. You kind of have to relearn how to study and what works for you. So kind of giving yourself a lighter course load and a little bit more time to adjust is always helpful. I think a lot of people wish they would have done this, but also timing is important, right? So maybe that just January start works better for you for whatever reason. And you get a summer break, which you never really get again. We do have a dual degree program as well with Mount Sinai. So you are able to get your master's of public health at the same time as your doctorate of podiatric medicine, if that was something that interested you. Fun facts about NYCPM, we were the first podiatric medical school in the United States, and we account for over 25% of practicing DPMs, and we have a very active alumni base, so that is a huge networking advantage. And it is very much a trend in podiatric medicine to have group practices, so I think that that's really great. Dr. Prevete also talked about our hands-on clinical training. Like that is what we are known for. Residency directors know that our students are very prepared for that because, I mean, we're located in New York City. So obviously our students are exposed to so much simply by rotating at these hospitals in this major city. But obviously outside of that, it's very hands-on as well. So you see pathologies that you might not even see during your 3 years of residency. We are very, very known for our clinical training. We have 100% residency placement. Actually, in this field, there are now more residencies available than there are residents applying for that. It wasn't always like that. Obviously now it is, so this is a great field to choose, but at this point, in the past, even there was a 30% shortage in residency placements, and through that, we still had 100% residency placement, and that's because of that clinical training, right? Like I said, residency directors, they know that our students are well prepared. New York City is a great place to study medicine. You really get exposed to a lot, and obviously it's a fun place to be as well socially. And what free time you have, what little free time you have, you're kind of in the greatest place to kind of use that free time. We're going to have student activities like clubs and such. You know, we are a school. We have a full-time faculty in the preclinical sciences, so we have a really dedicated faculty there to help anybody. Okay, that is the end of my quick little spiel. And this is the end of the webinar officially. If you guys have any questions for me as far as admission stuff goes, I will hang around for a little bit. Otherwise, you are free to go. Thank you so much for attending. And thank you again, Dr. Prevete. This was great. I really enjoyed it.